At this time, I'd like to present the Congressional Leadership Award. Congressman Frank Pallone, Jr., New Jersey in the 6th District, has represented Central New Jersey in Congress since 1988. Throughout his career, Congressman Pallone has been a leader in protecting the integrity of the Medicare Guarantee and Medicaid programs, making the nation's food system safer, strengthening laws to keep our air and water clean, making health care more affordable and accessible, and supporting initiatives that advance and protect the public health. Congressman Pallone is the ranking member of the House Energy and Commerce Committee, which has jurisdiction over issues pertaining to energy, environment, health care, commerce, and telecommunications. From 2006 to 2014, Congressman Pallone served as the top Democrat on the committee's subcommittee on health. As chairman during the 111th Congress, Congressman Pallone played a key role in authoring and passing the Affordable Care Act. The landmark law extends health care coverage to millions of Americans, as you guys know, while driving down health care costs and reining in abusive tactics used by insurance companies to deny medical treatment. Congressman Pallone was born and raised in Long Beach, New Jersey, where he still resides. He is a graduate of Middlebury College, holds a master's degree in international relations from the Fletcher School of Law and Diplomacy at Tufts University, and earned his law degree at Rutgers University. He began his political career in his home city of Long Branch, getting elected to the city council in 1982 and winning re-election 4 years later. In 1983, he was elected to the state senate representing the Monmouth County coastline and was re-elected in 1987. On November 8, 1988, at the young age of 37, Congressman Pallone was elected to the House of Representatives from New Jersey's former 3rd District and was re-elected in 1992 to the newly formed 6th District. Congressman Pallone and his wife Sarah have 3 children, daughters Rose, Marie, and Celeste Teresa, and a son Frank Andrew. And at this time, I'd like to ask Congressman Pallone to join me so I can give him his Congressional Leadership Award.
I'll hold it like that. Sure. I gotta make sure I don't drop it. Put it back up here. Sure. Thank you, Robin. Thank you, Robin. Thank you. I want to make, she said, don't drop that. I said, I want to make sure I don't drop it. It's too nice. I'm going to put that in a very prominent place. Thank you. And thank you, Robin, for all you do with the Healthcare Brain Trust, with the CBC. I was telling Robin, and oh, by the way, congratulations to Tim Robinson as well. As some of you know, he's the chief counsel for our committee, for the Energy and Commerce Committee. So I'm like honored to be up here with you, Tim, as well. But anyway, I wanted to say that Robin does a great job. I've never been to this conference before. I was telling Robin and Tim, but I actually have been when the CBC has their annual conference, I guess in the fall. I've been to some of the panels where the Healthcare Brain Trust has different panels. And actually, before Robin, I worked with Donna Christensen, because she was on our committee on a number of health disparities issues, particularly with regard to the territories, where we still have, even though the Affordable Care Act made some major progress, it's still not the same. They're not treated, people are not treated the same with regard to a number of our federal programs the way they are in states, and that needs to be changed as well. I don't want to speak too long, but I just want to say, as was mentioned, I was very much involved with the Affordable Care Act, and certainly we've made a lot of progress in terms of dealing with some of the disparities disparities issues. Obviously, Medicaid expansion has been very helpful. The subsidies that make it possible for people to buy health insurance on the exchange. All these things have made a big difference in terms of covering many people who did not have health insurance before. But, we still have a long way to go, particularly with regard to those states that have not expanded Medicaid, which are some of the most significant states with minority populations. I was with Sheila Jackson Lee and Jean Green at the Texas Medical Center, Texas Children's Hospital, I guess about 6 months ago, and we were in the lobby of this beautiful building that was just next to the emergency room, and I said to Sheila and Jean, I said, who are all these people hanging around in the lobby? It was like a hotel lobby, and people were laying on the ground, and they said, well, those are the people who would have been eligible for the Medicaid expansion, but now they're still using the emergency room because we never expanded Medicaid in the state of Texas. So, we have that still out there, which is millions of people. And we also have the threat, of course, of King versus Burwell with regard to the subsidies. And even in my own state where we expanded Medicaid, we don't have our own exchange because our governor decided for political reasons that, he was going to take the money to expand Medicaid but didn't want to have a state exchange because he could continue to, badmouth the president and talk about how bad Obamacare is as he was on the road. So, for political reasons, we still have a long way to go. And we also have a long way to go in terms of implementation of the ACA in various programs. We still have problems with access because people who have Medicaid or even have private insurance on the exchange oftentimes can't find a doctor, depending on whether in their state, Medicaid may not have an adequate reimbursement rate, or they just may be located in a place, either in a rural area or inner city, where there aren't a lot of health professionals or a lot of specialists. That's why I think it was so important that we passed the doc fix. I don't even like to call the SGR the doc fix because, as far as I'm concerned, as important as that was, the expansion of the CHIP program for kids and the expansion of mandatory funding for a couple years for community health centers was just as important, because I know in my district and around the country that even if a lot of times people will have to go to a community health center because they can't find a doctor that will take Medicaid, or they can't find a specialist even with private insurance unless they go to the community health center because of their location or their particular circumstance. We still have a long way to go in terms of research, too. Tim and I were talking about 21st century cures. I guess there was a panel or there was discussion about that today. Because if we can do this on a bipartisan basis and get this 21st Century Cures initiative moved, it may go far towards new cures and new therapies and new treatments. But again, we have to make sure that when we're investing money at NIH and we do clinical trials, that we have proper representation on the various trials. We have to make sure that that NIH funding goes towards research that impacts people, whether they're minorities or whatever, so that we have a good mix, so that our studies are actually useful in the long run. And we also have to be concerned about programs not only under the ACA, but in general for health professionals, that we have enough representation and diversity with healthcare professionals. I'll stop because I don't want to keep talking. You're honoring me, and I appreciate that. I don't want to just go on and on. But I actually came, I know, Robin, but I want to mention one thing. I actually came to the whole issue of disparities and ended up working with Donna Christensen because of my work with American Indians. When I got on the Energy and Commerce Committee, I was approached by some tribes, not because of their casino interests, because we have our own casinos in Atlantic City, and we don't even have any American Indian tribes in New Jersey. But I was like this, perceived as sort of this bleeding heart liberal, so they came to me and said, we have all these disparity issues with American Indians, and talk about disparities. I mean, it's unbelievable. I think in the entire United States, there are less than 500 doctors that are American Indian, just to give give you an example of disparities. So we still have a long way to go, but I know that the Brain Trust is a big part of the solution to all this. So I thank you again, and I really value the fact that you gave him this award. Thank you, Robin.
Congratulations again. At this time, I'd like to bring up Brandon Garrett, my Chief of Staff, or as he says, Chief of Stuff, depending on what is needed to give out the Staff Award.
Hey, good afternoon, everyone. Thank you for your attention. I also want to, while I have this chance, plug the Team Kelly that has worked so hard on putting this together. This is our first time here, and so, give the freshmen a round of applause. Really quickly, Brandon Webb, he handles our policy stuff, so there's Webb. Our B2 or Webb, or we have Audra Wilson, who's our Deputy Chief of Staff. She handles everything that's happening back in the district. Casey Atayero, and she's our communications director. And the man, the myth, the legend, Matt McMurray, he's the one that makes sure this thing is streaming live and the website's together and all of that. So thank you guys, you make everything a bit easier. Okay, so let's go to the real reason we're here, Timothy Robinson. Mr. Robinson, throughout his professional career, Tim Robinson has worked as an attorney and a government policy advisor. As Mr. Pallone said, he currently serves as Chief Counsel for the minority of the House Energy and Commerce Committee. Tim is the first African American to have been appointed to such a senior position on the committee. The Energy and Commerce Committee, or ENC as it's sometimes called, has expansive jurisdiction over healthcare, energy, the environment, telecommunications, and the internet, manufacturing, consumer protection, highway safety, as well as certain aspects of trade and the environment. So this gentleman is fairly busy. Before becoming Chief Counsel, Tim was the Senior Policy Advisor and Legislative Director for Chicago's own Congressman Bobby Rush, in addition to being a Senior Counsel for the Energy and Commerce Committee. He has held several other senior management attorney positions, including serving as General Counsel to the D.C. Public Service Commission and a Legislative Counsel to Ameritech and SBC Communications, which were merged together to now be known as that little company we know as AT&T. Tim started his legal career as a communications associate in the Washington, D.C. office of Skadden Arps, where he represented a mix of wireless, broadcasting, health, wireline, satellite, and emerging internet service companies. He received his law degree at the University of Virginia Law and his undergraduate degree in political science at Brown University, where he was a member of the Lambda Zeta chapter of Kappa Alpha Psi. Plug. He is a longtime resident of Washington, D.C., and remains actively involved in civic and community affairs. Ladies and gentlemen, without further ado, Tim Robinson, Esquire. Oh, sorry. I'm trying to get more people from the staff to come out to the staff.
Take your fraternity picture.
Okay.
There you go. They look like the singing group.
Okay. And I'll bring this down for you.
Wait, one more.
Oh, okay. Thank you. I'll take this down.
Good afternoon, everyone. I am humbly honored to be the recipient of this award because it comes from my colleagues. But it also has special significance because I'm receiving this award at an event which is centered around themes dealing with disparities in the healthcare industry, but it's easy for me to extend many of the aspects that are dealt with in addressing these disparities, closing gaps, in order to bring an equilibrium of benefits for all people, no matter where they come from, no matter what their socioeconomic status happens to be, no matter what their pathways to care might look like. Just in looking at disparities and how differences, cultural differences, and how those differences impact upon the delivery of health care for healthy bodies, healthy minds, healthy communities and neighborhoods. It informs and it lights up the importance of making sure that inputs into this governmental process are not blocked, so that stakeholders of all races, from all communities, have an ability to weigh in and impact the decisions that come out of Washington, D.C. and that emanate all across this country. The Affordable Care Act, rightly so, focused on prevention and performance, aligning payments and incentives around performance. And in many ways, that was the special sauce to enable us to bring our nation back to a place that was more healthy economically, but would also afford opportunities for better living and healthier lives for its citizens. It's important in that Congress, as the holder of the purse, and that the Energy and Commerce Committee, which played such an important role in drafting and crafting legislation, moving that through the legislative tangle, it was just so important for us to make that journey back to a more sound fiscal and economic footing and raising productivity in our country, to look at ways that we could keep people as healthy as possible. But there were some shortcomings. You know, no piece of legislation is perfect. There are still shortcomings with respect to closing the gap around those persistent disparities that plague our communities and we as African American people. Even on the Hill itself, it is not the most diverse place. And I want to thank Congressman Pallone for having the confidence and the trust in me to bring a perspective into his leadership that has historically been excluded or not as incorporated as much as it ought to be. I see that as a very important gesture and a very important component of that sacred trust that we as legislators, legislative staff, and policymakers in this city have. It's a very important duty. It's a very important responsibility for us to weigh in, for us to receive your ideas, your comments, and your inputs to influence policy and to influence legislation. You know, as a black man who has seen quite a few birthdays now, I know myself that I've bucked the statistical probabilities. I grew up in Mount Vernon, New York, a place which throughout my life I've seen opportunities present themselves for individuals like myself. It's a community that is 60% African American. You know, I noticed as we moved from the south side to better neighborhoods on the north side, our healthcare outcomes were different. Our lifestyles, our way of living improved. You know, and it is a community that is riddled with gun violence still. But in looking at prevention, you know, I want to also thank the organizers of this event, especially Congresswoman Kelly, for making it a point to look at the implications of expanding public health to look at how violence plays a role in how people live their lives and are able to live it more productively and more fruitfully. I again am very honored to be receiving this award. Thank you so much.
Now I would turn the mic over to Stefanie Brown James, and Tim, congratulations again, and Congressman Pallone. We will have a discussion on the state of Black America, so if everyone could come up. Daniel Dawes and Dr. Opella Ernest. You good?
Good morning, everyone. Good morning. Oh, no wonder why you didn't reply. It's afternoon. Good afternoon, everyone. It is indeed a pleasure to be here with you today as we talk about the state of Black health in America. There couldn't be a more timely topic, really a topic that never should be off of anyone's agenda, especially as health professionals, as policy leaders. And so we're looking forward to having a very vibrant conversation today, and one that is focused not just on research, but also on action, which I know is a primary concern for the Congressional Black Caucus. And I want to thank the Congressional Black Caucus for putting on this great opportunity along with the National Minority Equality Forum. And thank you so much, Congresswoman Kelly, for your leadership on this issue. Now, we're going to get right into the conversation. We have two experts who are not only practitioners, but they are policy experts. They are in the field every single day working on the state of Black health. And so I'm going to give very short bios. Please, I encourage you to view their entire bio online. And let me just say, this will be an engaging conversation. Now, my mother was a school teacher, as was my dad, so I believe in classroom participation. Okay, everyone? Okay, so get your questions ready because we're going to make sure that there's enough time for you to engage with the panelists as well. So first, we have Dr. Opella Ernest, who is the Divisional Senior Vice President of Health Care Delivery and the Chief Medical Officer for Blue Cross and Blue Shield of Illinois. She oversees strategic direction of Blue Cross and Blue Shields of Illinois' network development and management, leading a team that works with nearly 65,000 network providers and 1,000 network facilities. Her team is responsible for providing relationship, connectivity, and engagement, and also as the Chief Medical Officer, she also ensures that the company's she serves as the company's Chief Physician Representative to help ensure effective and efficient delivery of quality medical care. Dr. Opella Ernest. Thank you. And next we have Attorney Daniel Dawes, who is a healthcare attorney and the Executive Director of Government Relations, Health Policy, and External Affairs at Morehouse School of Medicine in Atlanta, Georgia. In addition, Attorney Dawes is a lecturer of health and policy at the Satcher Health Leadership Institute, Senior Advisor of Health Policy for the Transdisciplinary Collaborative Center on Health Disparities Research. I hope that has an acronym. Goodness. And holds a faculty appointment in the Department of Community Health and Preventative Medicine. Please, let's welcome both panelists today. So, there are a number of priorities that the Congressional Black Caucus has set out as it relates to addressing health disparities in our country. And I love that one of them is making sure that we can work to achieve health equity in a generation. This is an issue that while we need to be long-term looking, we need to be immediately focused on solutions and what we can do now to make sure that we close the health disparities gap in this country. So we're going to have presentations by our two panelists to give information about their area of expertise, and then we will go into questions and then questions from the audience. So first, we'll have Dr. Ernest. We'll begin with her presentation.
Thank you for that wonderful introduction. Congresswoman Kelly, thank you for inviting me and team. I know how important the team is, so I have to certainly acknowledge the team for this nice event. And thank you all of you for allowing me to be here today. We're going to just start out with the very obvious truth is that the conversation is about the town hall discussion of the state of black health. And I work for Blue Cross Blue Shield of Illinois. And this is a journey for us. So the content that I'll be sharing today is really sharing our journey, because we're on a journey in terms of how we improve the health of our communities in general. And this has been a big part of, I joined the company in 2012, and at that time we were already preparing for implementation for the Affordable Care Act. So I've been a part of a very historic time in the company. So I want to share that journey with you and also talk to you about why we decided to do it and where we are right now in that journey. My comments will be brief because I also want to leave time for discussion, and I'm going to learn how to use this green button, and I don't want the banana pudding to set in on you while I'm doing that. So who are we? First of all, we'll talk about who we are, what's our commitment, what's our experience, where's our current state, and what is our focus. And that's a really important framework for us. We are a healthcare service corporation. We are the fourth largest healthcare insurer in the United States, but Blue Cross Blue Shield of Illinois, which is what I represent, we're actually part of 5 Blues plans of our parent company, which is Healthcare Service Corporation. The corporation, as stated, has 5 Blues plans, but we also have 9 other companies that are either wholly owned or subsidiaries. The key important piece for this to tell you who we are is really the third bullet point, and it really talks about we're pioneers. So we started in 1936. We were pioneers at that time, and we are still pioneers when we think about ourselves and the Affordable Care Act, in the sense that we obviously have launched and are successful participants, but most important for us, we've also been leaders in some of the value-based care models. And value-based care is a term that you see as physicians all the time now, or everywhere, where you really think about the triple aim and how are you going to work with providers to improve both cost and quality. And we've been leaders in that space, and we're excited about continuing to develop that. The key phrase, though, for us at HCSC is the term, our commitment. And we talk about this all the time. We're dedicated to expanding access, quality, and cost. And so when people ask us, were you going to participate? Why did you participate? We always go back. Everything we do is with the same lens. Is it going to either increase access? Is it going to help us improve our quality? Or will it be cost effective? But the piece that we know that's even more important now is how do we empower our members to make decisions? We know that even with access, quality, cost effective, we still have a layer there, and that is how do you make your own decisions about your own health care? That's really important, and now providing the tools to do that are even more important than ever. So that's a big piece of what we're focused on. So what's been our experience? Well, as you know, this is the second open enrollment for us, so we do have some data from year one, and we really feel like once we have a good 18 months of data, we'll really be able to speak more clearly about what we've seen with the population that we began to serve with the Affordable Care Act. But just within the first year, we know that we have increased access to health in our communities significantly since the launch of the Affordable Care Act, what we call our retail membership. We have most significantly, and what I like to look at are our biometric screenings. And I say that because knowing your numbers is the first step. And I think when you think about what you can do in the community, anytime you have an opportunity to partner or to figure out how to help people know their numbers, it's really important. You know, health fairs, I noticed that that's something that you listed as an opportunity for you. You would be surprised, or you're not surprised, at how often that those screenings actually lead to a change in people's lives. I know we partner with the First Ladies in Chicago, and they do blood pressure screenings and glucose, and everybody gets together in different community segments. But we have had so many people diagnosed just by that one blood pressure screening. So it's really important to me, the biometric screenings, know your numbers. I'm particularly proud of some of the success with that. The well visits are also important for the children. We all know that our children are facing some very difficult challenges. Our diet being probably the one that's driving sort of the obesity issue, which leads to some of the other issues that we have downstream. So the well visits are so important. And then certainly maternity is an issue for us. Still, prenatal early deliveries are still obviously impacting our community. So our experience specifically to our membership in Illinois, there was over 500,000 people actually who got insurance because of the Affordable Care Act. This gives you the statistics for our other plan, and I only share that just to have you compare and contrast to Texas. So even though we're a large market, you can see that the Texas impact was fairly profound in Texas, and smaller impact in Montana, New Mexico, and Oklahoma. One of the things we noticed, though, and we talk about the state of black health, which I found just interesting, of course, is we talk about access a lot, but when we look back and look at the numbers overall, which you guys all have access to for the Affordable Care Act, it's still less than 20% are African American. So even with access, we still have opportunity to increase that number, and even to see that number increase would be considered a success. So what's our experience in terms of in general? We talk about our experience. Again, our book of business is not segmented at this point in time based upon our Affordable Care Act experience in 1 year specifically to say that these types of programs have had direct impact. But I can tell you that directionally, I put this here because the one that I'm most interested in is the behavioral health piece. And as a company, we have behavioral health programs. We have created access for people to see clinicians, to be treated for depression. It's a big issue for our community. It's still probably the one health problem that is not talked about a lot. I mean, I think we all know diabetes, we all know high blood pressure. Mental illness is still something that's rather taboo in our community. It absolutely impacts chronic disease. We know that 30% we do know from our own data that 30% of the chronic diseases have a secondary underlay related to mental health. So the opportunity for us in this particular space is important. And I see that when we talk about the state of black health as a major opportunity. We still don't have, a spokesperson, may it be an athlete or a business person or anybody that really has really told the story about mental health for our community and the impact. So I see that as an opportunity when we talk about the state of Black health. I can't talk about the state of Black health actually without talking about the number one though, which is the weight management piece. We do have an issue that is causing quite a bit of contributing to some of the key chronic diseases in our community, and of course smoking is also something that we have to think about and how we manage that in our children. So the second open enrollment, this is what we know so far. We're still not at the 20% mark. After we're in the second OEP period, we are not at 20%. We are hearing, or we believe that based upon those who enrolled nationally, about 14% have been identified as African American. And based upon the website, and this is their terminology from that says that for our Medicaid expansion piece, right now in the state of Illinois, we're at 39.3%. So I can't share all of our statistics, obviously, yet for open enrollment, but we absolutely participated in Medicaid expansion and prepared ourselves accordingly, and we do now have membership in Illinois. So what's been our focus? Our focus is really threefold. I talked about our commitment, access, quality, cost, and how do we do that? Well, one of the things we do is the value-based care piece. So when we talk about the Affordable Care Act, I think people often talk about the insurance piece of it, but there's another piece, and that was the directive piece of it. But there's a directional piece, and that has to do with, again, the triple aim and some of the funding, the shift in terms of pay for value, cost, and quality. So we've been early adopters in the space of accountable care organizations in our, and we have now I think up to 8 or 9. We have a very large book of a lot of members in our accountable care organizations and our intensive medical homes. And why is that important? Because it gives us an opportunity to work directly with our providers. And so one of the things you think about when you think about the state of Black health, once you get past access, you still have, once you're in the system, you have some inherent biases once you're in the system. And so by being able to work with our providers directly, we can first of all help in some of the educational pieces of as it relates to health disparities. So one of the things we did is by having that direct relationship with providers, created incentives around educating providers on how to and the things that they can do for specific segments of their population, and of course provided them the tools to more effectively manage their population. And why is that important to us? Because if we don't go to the doctor, which sometimes we don't, that's part of one of the things we need to overcome. At least the doctor knows you didn't come, and then they can figure out ways to incentivize you to come, and that will be the first step to overcoming access. So the fact that value-based care models are super important. Our intensive medical home, where we actually put a nurse in the doctor's office who is there with you and saying, instead of you having to be a phone call or what have you. But again, any opportunity to bring resources to you as a patient or as a member are impactful. The other thing we're focused on, they're threefold. Again, value-based care models, because we can work with the provider directly and help improve care. We can't practice medicine, but we can offer many tools to support our providers. Member engagement, multiple modalities, because we know that people want to engage with their health at all times of the day, at all times of the night, and they don't want to be limited by a particular way of communication. So we're focusing on how we can make sure to support our providers so that they can interact with you as in many ways as possible to help you manage your health and manage chronic disease. We've seen, not just with diabetes and hypertension, but we have seen some successes with other chronic diseases in terms of some of the technology available to manage and interface more effectively with the healthcare system. People often talk about telehealth and, actually the effectiveness of telehealth in mental health. Again, I go back to mental health because it's a big issue. Being able to get care in a private situation using telehealth is also something that, it's just when you think about multiple modalities, you're thinking outside the walls of the clinician's office. And of course, cross-functional teams. So part of what creates and supports the disparity is the fact that nobody's talking to anybody. So from a health plan standpoint, we see our role as sort of the helping facilitate communication, so sort of having a person there to let the teams talk to each other. So I know all of you have either personally or either had a family member go through, say, if a cancer or a diagnosis, and the number of the disconnection, even when you have insurance, and the lack of communication is just astounding in terms of your ability to actually create a care continuum. So member engagement with respect to forming the team construct is important. And finally, and probably most important when we talk about the state of Black health, is community partnerships. So we have, and this is a statement that's in our social responsibility report, but I put it here because it's important, because we have increased our investments in healthcare disparities. We're really focused on partnering in the community. This is where we have seen profound impact. And so I want to share a couple examples with you. The one that I'm going to focus on is basically the Sinai Health, which you know in Chicago. We partnered with Sinai Health Institute, and we took two communities. And in Chicago, there's a North Lawndale and South Lawndale. And North Lawndale is a predominantly African American community. South Lawndale is a predominantly Hispanic community. Both communities impacted by, of course, both lower income communities. And we took a model and we partnered and we funded it. And partnered to create the door-to-door model. So the community worker model, where they actually went and knocked on doors and got people to to be evaluated for diabetes, and link them back to the healthcare system. And if they weren't home, they went back. But the conversation occurred in their homes. It allowed people to sort of have the conversation, be screened, talk about family members that they wanted to be screened, get them to the clinic, and then once they were in the clinic, they actually saw improvements in their hemoglobin A1C. So the results are profound to date in terms of that community worker model. So our next step recently is we funded the Institute of Medicine of Chicago to, again, try to create other innovative models. And I'm passionate about that because, access is important, but care in your area, in your community, the type of partnerships that we have seen by partnering in the community and focusing and partnering with organization has been profound. And I just want to share that as when we think about the state of Black health, how can we utilize our community partnerships to make it comfortable for us to receive care in an area and where we live, reside, and work. So with that being said, I'm going to be followed by this esteemed lawyer, attorney, accomplished young man. And so I told my kids last night when I was reading his bio, I said, really, he's really accomplished so much. I'm so proud of you at Morehouse, and only would hope that I have two young men. So I always look for opportunities for them to read about accomplished African American men. So thank you for your time today.
Can you scoot down?
Good afternoon, everyone. It's so good to be among old friends and colleagues. I always look forward to this time, and I want to thank you so much, Stefanie, for the warm introduction. I want to thank you, Congresswoman Kelly, for the invitation to participate in this dialogue, and to thank you. I want to recognize and thank you also for assuming this very sacred duty as chair of our Congressional Black Caucus Health Braintrust. So thank you. I was reminded, thank you guys, yes, absolutely. I was reminded about a few weeks ago, about an episode that happened last fall. I was attending a conference on mental health and behavioral health. And one of the speakers got up and said that, gosh, I feel like every week there's a new conference on health disparities. And he said it with a little attitude. And I said, gee, when I got up to speak, I said, isn't it great that now we've reached this point where folks actually are addressing this issue? They're giving it the attention it deserves because it's a critical issue. And I think this is a testament to the incredible advocacy work among all of you guys. So we owe you an applause as well. Thank you very much for keeping this issue alive and well as we move forward. Now, as we celebrate the 5th anniversary of the Affordable Care Act, we have seen significant increases in health insurance rates among African Americans. We've seen some decreases and some disparities relative to access to care as well as quality of care. And in fact, the National Urban League has said, and I think this is for the longest while, it was very flat, they have actually seen an increase in the health index due to these factors. So that's great news. Overall, we've seen a reduction in the uninsurance rate among all racial and ethnic groups, but the big winners have been African Americans, Hispanics, folks in rural areas, as well as young adults between the ages of 18 and 34. And you heard the Surgeon General this morning talk about the fact that we have seen the uninsurance rate among African Americans decline by 41%, or 2.3 million new enrollees in health insurance. But what I want to emphasize is that African Americans are still experiencing little benefit from the considerable healthcare spending in our country. And we'll talk about that momentarily. Just in case you're interested in terms of the disparities, how African Americans rank in terms of the overall population and among Caucasians, it's interesting when you look at the public health insurance coverage, African Americans far exceed the rest of the population, but when it comes to employer-sponsored health insurance coverage, quite the opposite effect there. Now, what we wanted to do was also look at the trend in terms of establishment of Medicaid in the 1960s, the CHIP program in the 1990s, and then against Medicaid expansion. And interesting, as you can see, apparently everybody loves children, and so we saw quicker adoption rates there. With Medicaid, you saw with the blue line there, you saw a slower move to establish the Medicaid programs across the United States. And now with green, I thought that we were going to be on a similar path, but at the rate we're going, we still wouldn't see all the states expanding Medicaid, and so that's a little frightening to me. It's also frightening because we have also seen that a percentage of the uninsured African American population, ages 18 to 64, decreased to a larger degree in states that expanded Medicaid versus those states that did not expand Medicaid. All in all, we're seeing 55% of African Americans live in these 22 states that have not expanded Medicaid, and that's why I'm a little frightened. According to the Pew Trust, according to the New York Times, one minority group less likely to benefit from health insurance coverage expansions moving forward is, guess who? African Americans. And it's because many of them will fall into the health insurance gap resulting from a failure to expand Medicaid. And you can see the mathematical trend there, what we think would happen in terms of Medicaid expansion. We still wouldn't even catch up to the fact that Medicaid, original Medicaid and CHIP, every state expanded by at least in 7 years. But again, even in 16 years when original Medicaid had all states come together, and that was Arizona as the holdover, we still wouldn't even catch up to original Medicaid at the point where we're going. And so we know that there are political and external forces preventing us from reaching that, which really begs the question that we need to start getting involved. I thought I would break this down for us in terms of a map. You see, as we all know, the controversy around Medicaid still rages in a number of states. And interestingly enough, this draws from the line graph that you just saw. But initially, when states were allowed to expand Medicaid, we saw the great state of Connecticut and then the District of Columbia expand, hop on that. And then in the next year, we saw Washington, California, Minnesota, and New Jersey expand their Medicaid programs. Only one did so in 2013, that's Colorado. And then thankfully in 2014, we saw a jump, and I was hoping that would have been a greater jump, but that did not work. And despite our attempts to convince lawmakers across the South and the West that Medicaid expansion would have a tremendous return on investment, would have a positive economic impact, that argument is no longer persuasive as we thought it would at this point. And we know, therefore, different ideological and external reasons, and we can get into that later. In addition to that, one of the things that we've been working on is to get as many African Americans in the health insurance exchanges. And, you know, interestingly enough, there is another critical issue that we need to look at. So while we're trying to increase the number of folks in the health insurance exchanges, and I work with a lot of groups both in Florida, Alabama, and Georgia to increase the number of African Americans, what's been interesting about this is we're still seeing HHS failing to enforce this directive in the Affordable Care Act in terms of getting the health insurance plans to actively address reducing racial and ethnic health disparities. And we haven't seen them taking any steps to really monitor this issue. And so, we're still waiting with bated breath in terms of the Supreme Court decision in June around premium subsidies, but I think this is one area that we can take immediate action on to push the plans. Now, I want to move over to HIT. As many of us know, HIT has certainly been one of those areas that has exacerbated disparities among providers and consumers, but I also think it has tremendous potential to help us significantly address health disparities. And it is the foundation for many of the delivery and payment system reforms that we've been hearing about since yesterday and today. Now, the original HITECH Act prioritized health equity, but unfortunately, with the ensuing regulations, they have not addressed this issue appropriately or in a meaningful manner. And every time that a reg comes out, whether it's a proposed rule or an interim final rule, they might address some health equity issues, but when it comes to the final rule, that trend has shown that it mysteriously disappears. And there's a host of reasons that they bring up for not including it in the final rule. Well, we just saw the release of the Stage 3 meaningful use rules from ONC and CMS, and CMS, again, has not addressed this issue in their proposed rule. ONC has, and they've mentioned this issue 12 times, in fact. So it just shows that we really do have a lot of work to ensure that once things are implemented, they are implemented and implemented well. So moving forward, so we talked about HIT being the foundation for many of these delivery and payment system reforms. Let's look at the status of quality and disparities. It's very, very interesting here because you'll see that African Americans actually cite two things that as their top social issues that they're concerned about. One is high quality health care. The other one is access to high quality health care information. This is according to a study that was conducted by the AARP. Well, interestingly enough, the Agency for Healthcare Research and Quality came out with its recent National Quality and Healthcare Disparities Report, and I was a little shocked by this graph. Basically, what we're seeing is that in general, states with higher healthcare quality scores tended to show higher disparities in care. And states with lower healthcare quality scores tended to show lower disparities in care. Now, interestingly enough, the South shows a lower threshold, I guess, with disparities, but they also have the highest rates of health disparities. So disparities in health status, which is overwhelmingly borne by African Americans. And my concern is that as we push for improving the quality of healthcare, there's a real possibility that this may exacerbate disparities in healthcare if we're not mindful. And you heard Dr. Wyatt saying yesterday that there's been a lot of talk about cost and value, but not enough about equity. And I think it's true that as we're improving overall quality, it doesn't necessarily translate to reducing healthcare disparities unless it is intentionally done. And so we've got to be mindful of that moving forward. There is a graphic talking about the quality improvements that have been made overall in our nation. However, few disparities have been eliminated. The concern is that the disparities in quality and outcomes by income, race, and ethnicity are large and persistent and have not been improving substantially. This is according to the Agency for Healthcare Research and Quality. And what's interesting, if you look at the disparities worsened side of things, you see adult current smokers with a checkup in the past year who received advice in the last 12 months to quit smoking. I mean, key. We see this across the United States. As we talk to health equity champions in various cities, we've heard from folks in Philadelphia telling us about African American women who are pregnant smoking so they can reduce their weight. We're seeing pregnant teens in Atlanta who are smoking so they can have a low birth baby because they don't want to have a vaginal delivery that hurts. So things to consider as we move forward because these are serious. Now, as we march toward health equity, the struggle does still continue. And as Marian Wright Edelman reminds us, a good president or a new Congress is going to be only as good as the citizens outside demanding it. I I'm reminded of Dr. Martin Luther King Jr. when he wrote in a letter to in a Birmingham jail that in any nonviolent campaign, there are 4 basic steps. Collection of the facts to determine whether injustices exist, negotiation, self-purification, and direct action. And I'm concerned about the degree to which African Americans have participated in civic engagement. The National Urban League, in its 2015 State of Black America report, said that that is one of the indexes that declined. And so we know that the struggle for healthcare in this country is really closely intertwined with the struggle for civil rights. And lest we forget the progress that we've made or lose sight of why we're here, this is a simple reminder. You'll see that over the last 25 years, we've achieved enacting major legislation into law directly addressing minority health or health disparities, right? 125 years prior to that, it took them that amount of time to actually get 4 major pieces of legislation tackling this issue in healthcare. And then, just to give you a snapshot of a 100-year period, 1865 to 1965, some of the issues that folks dealt with. We see, maybe not in the exact way, these things rearing its ugly head, but again, if we're not careful, we will continue to lose that momentum. So just something to think about as we're moving forward. Thank you so much.
So much, Attorney Dawes. And I'll tell you one thing, you could tell that this is a health conference with physicians in the room because it is really cold in here. So I'm sure you all are used to it. I'm going to try to get used to the temperature in the room. But thank you so much for those great presentations. And so you mentioned that, we're now in the 5th year of the Affordable Care Act, first being passed 5 years ago. I happened to work for the NAACP as their national field director, going around the country, making sure our units were educated and were advocating for the passage of the ACA. And fast forward 5 years later, recently my husband is transitioning jobs. We've lost our health insurance. So now we're waiting to get re-enrolled in health insurance. And going through that process, I was completely overwhelmed on what in the world to do to, as an individual, as a business owner, get my own health insurance. And so everything that we talk about is so important over these 2 days. But if people don't know how to access the insurance, how to access the information to help them make wiser decisions as it relates to their own health care, then basically a lot of what we do is in vain. And so I just want to know from you both, what are some best practices that you've seen on ways that the community has been engaged and educated to know how to make smarter decisions for themselves as it relates to their own health care or insurance?
Sure. I think you just captured it. The complexity, there is some complexity. All insurance has some complexity. And so the question is, how do you simplify that, and what tools do you use to simplify that? And so, I think best practice is really that simplification needs to occur from trusted community partners, because that's who you trust. So you need people in the community that can help, or embedded somewhere in the community, subject matter experts that can help people in an environment that's a trusted environment, because it's really overwhelming. And not just this particular piece of insurance, but all of us that have insurance, the complexity of understanding what's covered, what's not, what's in network, what's out of network. And you've got to learn it somewhere. And so, of course, those resources are embedded within companies, but again, it's really important that they also be dispersed and be available in areas where people live, work, play.
And I would just add, it's interesting, the folks who serve as navigators, we've seen some navigators do a successful job in getting folks enrolled. Some haven't been as successful in reaching out to communities because, as Dr. Ernest has mentioned, it's about trust. I think that is so key. If you're reaching out to these underserved communities, you have to already align with somebody who has developed that trusting relationship over the years. So I think that's key. And I think if you look at what we've been doing, not only at Morehouse School of Medicine, but with a network of folks who care deeply about this. We've been really trying to get folks to use the technology. We know a lot of folks have the smartphones. We've actually seen in our communities that a lot of African Americans might not necessarily have internet access at home, and so it's really helping them to navigate this piece. Even as an attorney, for me, it is so challenging sometimes going through, looking at the healthcare.gov website, trying to figure out, what does this mean? What if I select this plan, what is this going to? Yeah, it's challenging.
Yeah, it is.
And I think that's one of the issues that we really need to work on moving forward in terms of literacy and education. So,
and then you both have mentioned that research is so important. You mentioned with Dr. King's quote that you have to gather the facts and information. With this expanded coverage that we do see now in the States, how will that expanded coverage help us to gain more research that we can then utilize to address disparities that exist in our communities?
So one of the biggest issues for me is data collection. And I know that ASPE, the Assistant Secretary for Planning and Evaluation, they come out with their figures every single enrollment period. And we've been concerned that HHS hasn't necessarily really pushed for more accurate collection and reporting of this data. They say, and I understand, you can't require folks to disclose their race or ethnicity or other demographic variables, right? But we need to do more to educate minority communities about why this information, why this demographic data is so critical. Because you're right, we're then able to take that data and figure out, do we need to then target our outreach here in this community versus another one? We can't really do so because, first of all, HHS doesn't even believe in its own data. So that's an issue for us.
So then what do we need to do then to push for HHS to make this a priority?
Well,
and not just them, but also just legislators as a whole.
Right.
What is the advocacy that we can do in this field to be able to push for that to happen?
So I'll answer it in two ways. One is legally, HHS, according to the Affordable Care Act, all federal programs, activities, or surveys are supposed to be collecting this data. HHS has gone after the lowest hanging fruit in terms of the surveys, but they haven't necessarily done a very good job requiring this throughout all of their federal programs, right? And I understand their limited resources, I get it. The other piece of it, though, is the education component. And I think as providers, as folks that treat the underserved, take care of these individuals, we owe it to them to educate them about why this is important. So, you have the legal piece of it, but in terms of what we can do, I think there needs to be a concerted effort to educate folks about the value of this demographic data.
Mm-hmm. Absolutely. And Dr. Ernest, what have you seen, or what's been your experience with the population of Americans who are enrolling in plans on the exchange? Have you found that this population is healthier, less healthier? Any kind of experiences that you want to point out that you've seen recently?
Sure. We're still, again, evaluating collectively that experience, because for us, a year of data, and Lisa and I, we've been in business for 77 years, a year of data is not robust, but we did see pent-up demand. So one of the things with the Affordable Care Act is that obviously previously, prior to Affordable Care Act, you had certain diseases where you may not be able to get insurance, or if you were waiting for a transplant, you wouldn't have been eligible. So there was some pent-up demand for people who either were, seeking transplants or in the middle of complex care to enroll right away. They were early enrollers, because as you recall, or you may not, I shouldn't say as you recall, I'm not sure either one of us pointed out, but in the first open enrollment period, the majority of the enrollment was at the very last segment of the period, as opposed to early in the open enrollment.
I can't believe that.
That is true. It was all in the end, and so we did see, just from a clinical standpoint, I can say that some pent-up demand with the initial open enrollment. I can't speak to this year's open enrollment, activity yet, but one of the things we did see when you talk about is that what you spoke to earlier about your experiences, the types of questions that we received during enrollment were far greater in complexity than what we had ever previously experienced in our history as a company. So so people had such complex questions, and it took, and it was, that it actually at times impacted our ability, our customer service ability to deliver, but which we resolved and addressed. But it was significant, and it just understanding that it was so complex that it required really a lot of time for everybody to sort of understand.
So going back to 2012, we had a very robust campaign season. I was fortunate to work on the Obama campaign, and one of the things that we talked about the most in reaching out to the African American community was that with the ACA came expanded coverage for preventative services. And I think, as you pointed out, Mr. Dawes, you mentioned that we now have 7.8 million African Americans who now have access to these preventative services, but there's still issues that we can see that we see in making sure that more people have access to preventative services. What are some of these issues that are still keeping people from getting access to the preventative services that we all know that they need?
So one of the things that we have been observing, and I'd like to do more research on this, is looking at the U.S. Preventative Services Task Force. Because as many of you know, they have the power to decide whether these screenings are rated an A or B, and they're at no cost sharing to the consumer. Well, a lot of the screenings, and we're hearing more and more from folks across the U.S. saying to us that, did you know that, for instance, the task force refuses to rate, let's say, glaucoma screenings, which we know disproportionately impacts African Americans. The same thing with violence counseling. It's been 20 years, and the task force still continues to say that there's insufficient evidence. They cannot score it an A or B, and so they continue to push it aside. And we know for African American males, for instance, this would be a great help. But again, this is when I was talking about the resources not aligning with the Black community. This is something that we need to be very mindful of. Looking at how the task force, the U.S. Preventative Services Task Force, what they're rating and how they're rating it. And I think we need to really push the studies and share these concerns with them as we move forward.
Thank you. So we're going to open up the floor for any questions that anyone in the audience may have. We have 3 mics here in the room. If you could please just give your name, where you're from, and your brief question. Yes, thank you.
Neva Lubin Johnson from Chicago, actually, and doctor, so I'm a provider. EHR, troubling for providers because it's been documented that it takes us 4 extra hours a week to use it. And so when you talk about how to provide quality care, they're not interoperable. Meaningful use staging is, we'll say, meaningless use, I think, for a lot. We agree about the need for data collection, but we also need to educate the majority on the need for data collection too, because I think the underrepresented get it. And then the last concern would be, I've applied to the new products with Blue Cross Blue Shield. I have not gotten a response, and having to reapply to insurers that I already belong to to be able to provide care to patients coming in new plans, it seems kind of onerous and unnecessary. And I don't know if anything can be done to streamline that process. And I'd also like a response, yay or nay, to that also. I mentioned that as an issue to the person yesterday with WellPoint. It's an issue for many physicians. So thank you for your presentations, timely and well done as usual.
Sure. Just for a second. So, for the sake of time, we're going to take your first question, if you all could address that. For your second question, if you could follow up with Dr. Ernest after. And also, this is being live streamed, so I want to encourage you to not use acronyms. If you can say, because I don't know what you're talking about. So if you could just kind of try not to use acronyms so that those who are watching know exactly what we're talking about. And please use the hashtag CBC Health so that we can make sure people outside of the room are getting information. Thank you so much for your question.
You're welcome.
Dr. Ernest.
Okay, so I'm going back to your first question was about data and electronic medical records. So I think the general response to that would be is we all know that technology has to be connected in order for it to be meaningful. And so now that it's not great, it's not there yet, but and it's not helpful to the provider. I know it adds some burden, but ultimately, in order for us to have data, we have to eventually figure out how to use it more effectively. Otherwise, we won't get to where we need to be to move the collective needle. So we need the data, and so we're going to have to, even though it's burdensome now to add and do the medical records, it's a piece of what we're going to have to do. We can't, manual won't work for where we need to go to really manage the health of the population. But I do hear your concern. The second concerns that you talked about and the specific concerns we certainly can address offline, and I'm comfortable doing that, and I'm comfortable hearing the question, which is why I come out, because our job is really to hear and understand and make your job easier so that you can go out and work and take care of people. So,
thank you. Thank you. So we're going to go over here to this mic, please.
Hi, I'm Cynthia Nandescansi with Families USA. Thank you very much for being here. I want to make one quick comment and one question. On the issue that was raised on what do we do about data collection at HHS, especially around the exchanges, one of the things that advocates have been meeting with HHS about is the importance of educating not just the community, but actually educating their own call center and making sure that the training for all of the navigators and assisters that they have to approve actually includes information on, first of all, you must ask the question, because often in the call center they don't even bother to ask the question. So even though you can't, the government cannot force anybody to answer the question, a lot more can be done on HHS's part to make sure that the question is actually getting answered. It's actually at least getting asked, because we're light years away from where we have to be on that. As far as my question, though, Daniel, you've talked about the fact that some of these improvements in quality across the board not only may not translate to quality for people of color and improving disparities, but may actually make it worse. So my question is, what would you say from an advocacy perspective should people in this room be doing to try to address that issue? Up at the federal level, where a lot of these standards, the more and more payment is tied to quality measures, the more there is a risk of entities that are right now struggling to keep providing care in some of these underserved communities will not be able to keep up.
That's an excellent question. I thank you for raising it. We're in this push-pull phase right now, right? And we're really going into this push phase more so, where the incentives that we've been getting from a lot of these delivery and payment system reforms are going to be turning to penalties. And I'm concerned as we move forward that a lot of these delivery and payment system reforms were developed without any insight from communities of color. A lot of them were created for a healthier and wealthier population, but many of the communities that we serve are lower income. There are all sorts of issues that we have to deal with, and they're not taken into consideration. And so one of the frustrations that I have with CMS really is this inflexible approach that they're taking. And I think it's critical as we move forward that they understand how important it is to bring folks that have not always been at the table on these issues, and a lot of our folks have not been on the table around these issues, to bring us together. I know the Learning in Action network that was established by HHS, many of these folks that have joined this network, they don't represent the communities that I work in, and that's frustrating. So I think, if I could sum it up quickly, it's really engagement, and re-engagement for some of us who were engaged previously, because this is sort of the unfinished business for me in terms of ACA, and I think it has the potential to create this separate and unequal system if we're not careful. So I agree with you, and I appreciate you raising that.
So we're going to have our final two questions. Yes, ma'am?
Melissa Robinson from the Black Healthcare Coalition in Kansas City, Missouri. Two-part question. One, we mentioned the ACO, the ACO, the Accountable Care Organizations. What can we do to prevent redlining from happening as it relates to, we know that healthcare is really commercialized, and we're looking at these big hospital systems where they're able to cherry pick the least high-risk population to create the ACO, where the high-risk populations aren't being included in that. So what can we do to prevent redlining from happening with the ACO? And then my second question, you mentioned about the community health workers. And what are the barriers? I don't know if you all are reimbursing for community health work in Illinois, but if not, what are the barriers to ensure that community organizations can reimburse for that effective model?
That's a good question. I can speak to that because we would not, our funding of that particular model is actually through the Institute of Medicine of Chicago on purpose, so they can help figure out, so there's not insurance, it's not a direct insurance initiative where we pay you directly. It really has to come from the provider. The provider actually deploys the community model, and so that's why we decided to give it to people who we think can do it best. And we looked to the Institute of Medicine to help develop that model. These are early models. I mean, what we funded for Sinai it was an innovation. It was something that we piloted, but the actual model a model that's been built, tested, researched, proven, this is all new. And so I think the Institute of Medicine of Chicago is well positioned to start that work, and there are others in that space. So I can't speak directly to the reimbursement from our standpoint. You may have something.
So, I can speak to the redlining piece. So I had a very interesting experience with the CEO of a major insurance company in Georgia. And I serve on the board of the Hispanic Healthcare Coalition of Georgia. So they wanted to really reach out to the Hispanic community. And when I said, well, how about the African American community? Well, you heard what I talked about. We actually have the costliest and highest disparities, right? He didn't want to touch the African American community. That just raised alarms in my mind. And I said, gee, now, one of the issues I see with CMS, and we're pushing CMS on this, is the fact that we do need you to start aligning resources, dedicating more resources to our underserved communities. Because what I'm afraid of is I don't want payers, I don't want providers doing exactly what you're saying, engaging in risk selection, moving away from our communities. That's frightening. We also see that happening within certain networks now, where we've had patients for generations in the West End area. We work with certain community health centers, and all of a sudden we see the hospitals that are 35 minutes, 40 minutes that never really cared about these folks, but now that they have an insurance, they want them, but they still want to leave then those that are uninsured who fall within that coverage gap for us to continue serving. So you see all these things happening, and I agree with you. It's something that we continue to press, and we need to work collectively on to push CMS so they understand how this impacts the type of communities that we serve and we care about. Thank you.
Thank you. Final question.
Thank you. My name is Tamara Duperval-Brownlee, and I currently work for Ascension Health, the largest Catholic health system in the country. But I come from a background of care delivery in underserved populations, both in Illinois and in Texas. So I went over to the system side just to address this very issue. And my question is, it's a voice that hasn't been really at the table. What are health systems doing? Our organization touches literally millions of people in 23 states. And without a unified agenda in addressing disparities. And I wanted to ask both of you in your experiences in any of the pillars in addressing health disparities, where have you seen some best practices on care delivery, community benefit, advocacy, research, in health systems? And if you had your moment with the king, if you will, in any of your health systems, especially national ones, what would you want to say in terms of advancing this agenda?
It's a good question. I was thinking of health systems, and if I name them, if I don't name the other one, and how I can answer that. But I can tell you that our early partners was Advocate Health System, which is obviously large for the Chicago area, and there are other health systems, President's Health System that serves populations, and they have all, they have done work to make sure that they're serving the community, but I haven't seen specifically any health system specific sort of road, what you're asking for, sort of that roadmap, that document. That doesn't mean that it doesn't exist, it's just I have not personally seen it with a health system name linked to it. I see a lot of collaborative effort in the Illinois market, but I can't speak directly to their playbook, so to speak.
One system that comes to mind, and I'm so grateful that the ACA really has a robust health equity agenda, because there are hospitals, there are health systems that, I have long yearned for them to address this issue, right? Well, the Adventist healthcare system here in Maryland has been doing a phenomenal job. They were working on this prior to the ACA. I think that they have some pretty good stuff, and they can share some of their experiences with you as well. So I'm happy to put you in touch with their executive director if you're interested.
Great, thank you.
I want to thank you all so much for your questions today. And as we wrap this session, in your brief closing remarks, if you can give us 2 action items that we in this room can take to make sure that we are working to advance the state of Black health in this country, that would be great.
I think what I said previously, remember mental health when you think about Black health, and also going back to our core, our foundation, and our communities to address issues.
I would say that we need to be creative as we're moving forward and designing, these health equity programs, and I would say engagement, absolutely critical as we move forward.
Awesome. Thank you so much. And thank you. As a person who's a soon-to-be mom, it feels very good to know that we are in good hands in this country with health experts and professionals like you all, and so many of you in this room. I encourage you to please continue this conversation. Make sure it gets outside the walls of the fancy Ritz-Carlton hotel that we're in.
Right.
Hashtag CBC Health, please utilize that. And thank you so much for your time. The next sessions are on respiratory health, heart disease, and stroke, so please go to the concurrent sessions that'll start in 10 minutes. And thank you so much again, Congresswoman Kelly, for holding this forum for us.
Thank you.
Thank you so much. Please, let's give them a round of applause. And Stefanie did my job, so as she said, the next 2 sessions will start at 2. We're going to split the room again, so thank you for your patience with that. Thank you, and enjoy.
Thank you.